Vinod, all good?
Yeah, ma'am. Ma'am, please share the screen. Ma'am, 1 minute, please.
Good morning, everyone. Apologies for the delay. I hope you all didn't miss me much in these 10-15 minutes and instead you revised some notes or you reviewed the questions that you did wrong. Am I right? I hope you all did this. Audio video fine? Am I stuck or am I not able to see responses? See, miss me so much that you continue studying dermatology when you miss me. That is the best way to remember me. I'll have hiccups also. You know, now we get hiccups when someone is missing us. So when you miss me and you are studying dermatology in lieu of that, I'm going to get hiccups. I will know that you guys are thinking about me. So audio video fine. That's great. That's great. Chalo. So how many of you over here have attempted questions? How many of you have done the paper? And very good, very good. So what was your thought when you were doing the paper? Were all the questions from what you had studied in the class? Very good. I'm seeing a lot of responses. Yes, mostly. See, dermatology is a very small and a sweet subject. Whatever you study in the class, questions are going to be from there only. Yes, they may turn and twist it a bit, but thankfully it's a small subject. There are no new guidelines happening here. There are no new drugs coming in every day. There are no classifications and cancer gradings updating here and there. So, derma is a very short, sweet subject. Whatever you study in the class notes, whatever you do in the class notes, it is going to mostly be coming from there only. Okay, it's mostly going to come from those topics. So if you do the class notes well, you attempt the MCQs that are there in your Q banks, that are there in the PYQs, in the GT discussions, you are good to go with derma. I will not be very worried about dermatology if I have managed to do all this. And these short subjects, they are your best bets in the exam. Not just derma, all the other short subjects, they all are the same, nothing new happening. You just have to study a small workbook and your one subject is completed. Very high yield, very simple questions that come from there. So not just focus on derma, I would say do the same for all the short subjects. So should we begin? Yes, we should begin. It's high time now. So silly mistakes, core topics are okay, miscellaneous feels tricky, 40 correct. So that's the whole purpose. Now exam is going to give you tricky questions only. So why should I stay behind? Why should I miss out? I will have FOMO, I will not have JOMO. So don't let me give you simple questions. Okay. Anyway, let's start. Let's start. I want you all to be solving the questions along with me. Let this not be a one-way discussion. So which of the following statements about skin structure and embryology are correct? The epidermis can regenerate from hair bulb and sebaceous glands. Keratohyalin granules contain filaggrin. Epidermis is ectodermal. Dermis and hypodermis are endodermal. See, dermis and hypodermis are endodermal? No. Dermis and hypodermis are mesoderm. So this is wrong. Epidermis is ectodermal origin. Correct. Keratohyalin granules contain filaggrin. Correct. Epidermis can regenerate from hair bulb and sebaceous glands. This sounds correct because sebaceous gland is correct, but are the stem cells present in the hair bulb? No, they are not present in the hair bulb. They are present in the hair bulge. So these are the kind of options where you tend to read it in a sentence. You think it is correct, but no, it is not correct. These stem cells are present in the bulge. They are not present in the bulb. So this statement becomes wrong. So what is correct? Only 2 and 3 are correct, which makes option B the correct answer here. So that is the confusion, and I want to clear your confusions. Thus, this discussion today. And mind you, this is an INI repeat. It was 2023 or 24, one of those. This question is a INI PYQ. So please remember, you don't just have to read the PYQs, read the PYTs, read about embryology, read about stem cells. So see, in the stem cells of the skin, the stem cells are present in the basal layer, which is the epidermis in between the hair follicles. So here you have the stem cells, then you have the stem cells in the bulge. So this is the bulge where you have the stem cells. And remember, they are not present in the bulb. And then you have them in the base of the sebaceous gland. These are all multipotent stem cells. These three are multipotent stem cells, and they not just help in skin regeneration, which is on a daily basis, they also help in wound healing. So this question has actually come in the INI twice. Once they asked, the wound healing of the skin can be from all these except. The second time they asked this multiple choice question. So a same question asked in two different manners in the same exam. So please remember, this is where you get these stem cells. This is about the wound healing and the regeneration. Then even in the dermis has its own mesenchymal stem cells. Okay, it has its own mesenchymal stem cells, but they cannot regenerate epidermis. These can regenerate epidermis, they can help in wound healing. This will only regenerate its fibroblast and its own cells. This is not going to regenerate the epidermis. So there is a difference here. These three cells are multipotent, they can go to any line and help in wound healing. But the dermal stem cells will just regenerate the fibroblast. I hope I'm clear about that. There is a difference. Stem cells, of course, you can find anywhere, but we are talking about the stem cells in the epidermis, basal layer, bulge, and the sebaceous glands. Then, question number 2. Identify the following lines. Identify the following lines. When you look at these lines, what do you see? First of all, there is a midline demarcation. Second, you see this spiral on the scalp. So when you see the spiral on the scalp, you see that the shape of the lines is different on different body areas. When you see these two things, that shape varies on different areas, and these are spiral. Where do you go? Are these relaxed skin tension lines? Those are Langer's lines. These are not Langer's lines. Are these dermatomes? They would be straight lines wherever they are. So these are not dermatomes. Marionette lines are on the face near the lips. These are lines of aging. These are the skin folds that develop due to aging. So these are not marionette lines. These are Blaschkoid lines. So by exclusion, by knowing the image, either way, you have to know that these are the Blaschkoid lines. These three lines we've done very nicely in the class when we were discussing, but this paper and this discussion may be also seen by other students who might not have seen the LFT session. So I will be doing all the discussions in a little detail here again. For those who have attended the LFT, it may sound a bit repetitive, but think of it as a revision. We are doing this revision. And for all the others who are just watching it as a test and discussion, this is for you all as well. So when you look at the Blaschkoid lines, these are lines of embryonal migration. This is the route which is taken by the skin cells, the keratinocytes, when they are moving to the epidermis. These are the Blaschkoid lines. Remember, they have no association with arteries, veins, nerves, or lymphatics. They absolutely are not related to any other linear structure. These are embryonal lines. How do you identify the spiral on the scalp, the different shape on different areas? That is what is the Blaschkoid lines. There are different dermatoses that can develop along these: epidermal nevi, incontinentia pigmenti, and hypomelanosis of Ito. What do they represent? They represent genetic mosaicism. They represent genetic mosaicism. What is mosaicism? When there is a post-zygotic mutation. So there are two different cell lines in the same person. That is what is called as mosaicism. So in the skin cells, when there is a post-zygotic mutation, these kind of diseases can develop: epidermal nevi, incontinentia pigmenti, and hypomelanosis of Ito. The distribution of these diseases is going to be Blaschkoid. Then we have the Langer's lines, which are also called as relaxed skin tension lines. They are oriented along the collagen fibers. And remember, their shape is not constant throughout life, because your bulges, your skin tensile strength, elasticity, everything changes throughout your lifetime. You may grow obese, you may slim down, you may sag, you may have an injury, you may have a long scar which changes your collagen fiber orientation. So these lines, remember, are not constant throughout the life. They are not constant throughout the life. This is the NEET PG 2017 paper. Image of Langer's lines is an INI May 23 question. So Langer's lines you have to be able to identify. And the best way to identify is either look at the bandages on the face or look at the neck. This V-shaped necklace on the neck is a very important marker. That's a very important hint that takes you towards the Langer's lines. One disease that happens along the Langer's lines is pityriasis rosea, where you see lesions along the lines of cleavage. That is the same as the Langer's line. And what is the importance? Surgical incision. Surgical incision is always parallel to these Langer's lines to give a good scar. If we give it perpendicular to these Langer's lines, there will be a risk of gaping, there will be a risk of hypertrophic and abnormal scarring if you are not able to orient it along the Langer's lines. And dermatomes are sweet little dermatomes. We are reading them since first year MBBS. This is the area supplied by a single spinal nerve. These dermatomes will always have a midline demarcation. They will be straight lines horizontally on the trunk and vertically straight on the limbs. So that is your dermatomes. One disease along the dermatomes is herpes zoster. Is that clear to everyone? Will you be able to identify these lines? That is very, very, very important. You should be able to identify these three lines. Now, question number 3. What is the morphology? Basics like these. No, epidermal nevus is not Becker's nevus. There's a difference. I'll be discussing Becker's nevus in one of the questions. It is in the options. So I'll be discussing it. But please remember, this is not Becker's nevus. These are different. For now, this is a question that you have to tell me, identify the morphology. These kind of basic questions, which you will like, I don't want to read morphology. I already know. Skin lesions, I already know. That kind of thought process, INI catches upon. It will ask you so basic questions that you will be like, Acha, this I've read, but I don't really know because I never focused on it. That should not happen. Basics have to be very clear when you are targeting exams like INI CET, and these days even NEET PG. They love asking these kind of basics. So identify the morphology. This is an INI August 2020 question, of course, with a different image. Identify the morphology of the lesion. So when you look at this lesion, this is an erythematous lesion with some pustules in it. It is ring shaped with a disease activity more prominent on the margins, and in the center there is clearing. So what is the shape of this lesion? The shape of this lesion is ring. Ring means annular. So this is a annular lesion. Very good. All of you have gotten it correct. But the major confusion here is annular versus discoid. Annular are ring-shaped lesion where majority of the activity, majority of the redness or whatever is the finding will be on the margins. Discoid lesions are like a disc. Disc is like a coin, or the disc that you play with in your parks when you throw it at your friends. So this is like a disc. This lesion is always going to be round or coin shaped, and there will be uniform disease activity all over the surface of the lesion. There is going to be no ring here. There are no inner margins, outer margins, nothing like that. So you have to know how to differentiate between these ring-shaped annular lesions and discoid lesions. That is the whole purpose of this question. Targetoid lesions will have different colored rings. Bullous lesions will be a fluid-filled lesion which is more than 1 centimeter. So the correct answer to this is option A. I've just put a few images here because in one of the INIs in May 2024, they asked all of the following lesions are annular except. So they will ask you an image of an annular lesion in 2020, then 2024, they will ask you all these lesions are annular except. Again, that is the importance of reading PYTs. The whole topic should be clear to you. It should not just be about reading the questions. Okay, so coming to these kind of annular lesions, look, they will always be like a ring. In the ring, this is your BB leprosy. Again, you see these ring-shaped lesions. That is why this is also called as annular leprosy. That is why this is also called as annular leprosy. And as a question, this has been asked in the INI CET as well. What is annular leprosy? Annular leprosy is borderline leprosy. Then we have granuloma annulare, which is another disease where you have these ring-shaped lesions. Again, annular lesions. Then pityriasis rosea has these annular lesions with peripheral colorative scaling. Porokeratosis was a new disease when this was asked in the INI May 24. A lot of students didn't know what porokeratosis is. This was there in the options and they had no idea. So I've put it here. This is porokeratosis. This is a disorder of keratinization. This is a disorder of keratinization. Here what we get are annular lesions, means they are ring shaped, but you see this thready border. You see this thready means very thin like a thread. They have this thready border or thready margin. That is what is porokeratosis. So even if you read it in the questions, even if you see this kind of a term, you should just somewhere know in the corner of your mind that this is what is porokeratosis. Okay, so these are the common annular lesions. Then we have discoid lesions, which are coin-shaped lesions. A classic example of this is nodular eczema, which is seen in patients with atopic dermatitis. You have this coin-shaped eczema rash. Then discoid lupus erythematosus, which is a chronic cutaneous LE. Again, you see this round rash with marginal brown pigmentation. These are all discoid lesions. A question in INI November 25 asked the sign in DLE. Remember, the sign in DLE is the carpet tack sign. The sign in DLE is the carpet tack sign. Then just telling you another lesion, that is serpiginous, just a few rarer ones of them. Serpiginous would be a curved lesion like a snake. This is cutaneous larva migrans. Where it enters the skin, it has this serpiginous root. So this is cutaneous larva migrans. And lastly, polycyclic lesions. Polycyclic lesions are when a lot of circles join. So that kind of circle outline that you get in the lesions, these are polycyclic lesions. Another very favorite term of the INI CET. They like asking the polycyclic erosions which we get in herpes genitalis. And they have also asked this before, polycyclic hypopigmented scaly macules are seen in pityriasis versicolor. So the only meaning of polycyclic is when a lot of circles join, the outline that you get, that is your polycyclic. So in herpes, when the vesicles rupture, the erosions tend to coalesce, you get polycyclic erosions. Same thing happens in pityriasis versicolor. So coming back to this question here, targetoid, so you know, is seen in erythema multiforme. We'll be discussing this in one of the questions. So I've not put an image here. And bullous, so you see in pemphigus and pemphigoid. This also we'll see in the subsequent questions. So for here, you should know that the correct answer to this is option A. Okay, this is option A. Next, we come to question number 4. You tell me the answer to this. So, can you tell me the answer to this one? Very good. Very good. Which of the following statements about telogen effluvium is true? So we have to tell about telogen effluvium. What is true? TE is caused by sudden premature shedding of anagen hair? No, not at all. This is something we see in anagen effluvium. This is something we see in anagen effluvium, where due to the cancer chemotherapy, or the cytotoxic drugs, the anagen hair are killed and there is a premature shedding of the anagen hair. So this is something we see there. Hair loss usually occurs 2 to 3 months after triggering event. Yes, this happens in telogen effluvium. Telogen effluvium leads to scarring alopecia with permanent hair loss. Not at all. This is a part of the treats, the effluviums here. Both anagen and telogen effluvium, these are non-scarring alopecias where there is a self-resolution and the hair regrows in telogen effluvium. It does not even require treatment. So there is no permanent hair loss. The hair is going to regrow. The pull test in TE is usually negative. No, pull test is generally positive. Now, what is pull test? When a patient comes to us, we take a tuft of maybe 40 to 50 hair in our fingers like this, and we tend to put a pull at it. We tend to pull that hair, and then we see how many hair come in our hand. That is what is called as pull test. And when a patient of telogen effluvium comes to me, the hair are actively shedding. So when I put a slight pull, when I tug at these hair come out. I have a lot of hair, not all of them, but about 10% of these hair will come out when I pull at these hair. That is called as the pull test. And this is generally positive in telogen effluvium. So Which of these is true? This is wrong, this is wrong, this is wrong. The only one that is true is B, where the hair loss happens 2 to 3 months after the trigger. And what are the common triggers for telogen effluvium? Let's just revise because this is a NEET PG 2022 question where this happened after COVID. So remember, telogen effluvium can be triggered by COVID, then any other febrile illness like dengue, typhoid, then by delivery of a baby, which is postpartum, and any event where there is a lot of blood loss, whether that's a surgery that's happened or a road traffic accident that has happened, where there is an extremely stressful event on the body, there's a lot of blood loss. These are situations that can trigger a telogen effluvium. And just for GK, I'll tell you, these days I'm seeing a lot of acute telogen effluvium patients. Who are these? These are patients who are taking Monjaro or GLP-1 analogs. What are they doing? What does GLP-1 do? It reduces your appetite. You don't eat, you tend to starve. So this kind of a acute starvation which happens due to GLP-1 analogs like Mounjaro or Ozempic, these patients also come with telogen effluvium. That's a additional trigger that I'm telling you. Yes, pull test is also positive in anagen effluvium. Anagen effluvium, you know what happens to the hair? Anagen effluvium, you just touch the hair and they will come in your hand. You don't even need to pull at them. That is the kind of shedding that happens in anagen effluvium, that it will just come out. So is this question number 4 clear? Clear. Now we come to question number 5. Again, this is a very, very, very favorite of the INI as well as the NEET PG papers. Tell me what is the correct answer to this. A 6-year-old child presents with patchy hair loss, scaling, erythema on the scalp as shown. Erythema you can't really make out in the picture, but there can be. Wood lamp shows green fluorescence. What is the type of fungal infection pattern seen in this case? Okay, so this is quite a simple one. So this is a child with patchy hair loss with the image showing a lot of gray colored scaling. Okay, so this has a lot of gray colored scaling. Even the question tells you that there is gray colored scaling, but the image is showing you that. And most important hint, green fluorescence on the Wood's lamp. Now, here you don't really have to make a diagnosis. The question is already telling you that this is a fungal infection. So half your job is done. This is a fungal infection. All that you have to do is identify whether it is gray patch, black dot, Pemphigus, or Kerion. Now, out of these, do you see the black dots? No, so this is not black dot. Do you see scutula-like crust? No. Do you see the red boggy swelling of Kerion? No. So when you see this gray colored scaling, you have to go to GMC as the mnemonic. Gray scaling caused by microsporum, and this is a C or an ectothrix type of infection. So the correct answer to this is option B, that is ectothrix. Endothrix would be BNT. This will be black dot. Kerion will be a red boggy swelling. It will not be like this. And it is also Wood's lamp negative. So this is anyway not Kerion. Pemphigus will show you scutula, and Pemphigus on Wood's lamp is going to show you a pale blue fluorescence or a blue-green fluorescence. It will not be just green. So this is not Pemphigus either. So every hint in the question, whether it is gray colored scaling or it is the green fluorescence, that is taking you towards gray patch, and the correct answer for this is ectothrix. See, these are the non-inflammatory variants of Tinea capitis, where this mnemonic is important. Gray colored scaling caused by microsporum, and this is an ectothrix type of infection where the spores are outside the hair shaft. When it is BNT, you will see these black dots in the patch, and here the spores are going to be inside the hair shaft. So this is an endothrix type of infection caused by the trichophyton fungi. Caused by the trichophyton fungi. Is that clear? Pemphigus The only question that has been asked in NEET PG 21, what is the causative organism? Causative organism is Trichophyton sholoni. And I told you for the INI, if they do a multiple choice question, favors on Wood's lamp shows a pale blue fluorescence. That is something that you have to remember. Chirion will be a red boggy swelling. There will be history of pets at home. And in such a patient, despite all the redness and the pustules, the pain is not going to be much. This is only going to be a mild pain. That is what takes you towards a chirion and not towards the pyodermas. Is that clear to everyone? These animals are here just to tell you that there can be a history of pets at home in the question. The next investigation in all types of tinea, whichever is the type of tinea, next investigation is always going to be a KOH, which will show hyphae, because this is a dermatophyte infection. Wood's lamp is going to show, see, this is the gray patch type of tinea capitis where you're seeing the gray scaling, you are seeing mild erythema. On Wood's lamp, this is giving you a green fluorescence. This is giving you a green fluorescence. So that is the Wood's lamp finding. Only oral treatment, drug of choice, griseofulvin. Do not mark any shampoos, lotions, or creams for tinea capitis. The only treatment that we use is oral therapy. We have to give oral antifungals. Drug of choice is griseofulvin, given at a dose of 15 to 20 mg per kg for 4 to 6 weeks. So please remember the whole figure, the dose, and the duration as well. Now, coming to question number 6. This is the little long one. Read this. Sorry for the disturbance, but I had the electricity going away at my place, because of which I had to reconnect it to a different source of power. So you can now see me better. I hope this is better. So coming to question number 6. A 15-year-old girl presents with abdominal pain. So this is a teenage girl who presents with abdominal pain, nausea, vomiting. Whenever you see pain, nausea, vomiting, you have to be thinking of GI obstruction. You have to be thinking of GI obstruction when you see pain, nausea, and vomiting. On examination, irregular patchy hair loss on the scalp with broken hair of different lengths, follicular hemorrhages is noted. Barium meal is shown below. What condition is this? So a very simple question. Patient here is coming with signs and symptoms of GI obstruction. On examination of the scalp, the patchy hair loss with broken hair with follicular hemorrhages goes towards a diagnosis of trichotillomania, and barium meal here is showing us this dense tuft of hair in the stomach. This is what is a trichobezoar. This is what is a trichobezoar. So a lot of patients of trichotillomania, these are teenagers, these are young adolescents. These people tend to have associated disorders of stress, anxiety, depression. And when they pull out their hair, they eat it. That's called as trichophagia. and over a period of time this can lead to formation of a trichobezoar in the stomach, which can cause GI obstruction. So is this a somatoform disorder? No. Is this a conversion disorder? No. Is this an obsessive compulsive disorder? Yes. Dissociative? No. So this is a classic example of an integrated question where you have dermatology integrated with psychiatry and even radiology or surgery. So this is what are integrated questions. They don't really come from somewhere on heaven. They are not dropped like this. They are integrated because by asking questions like this, they actually target three different subjects and test you with just one question. So what is the correct answer to this? The correct answer to this is option C. This is trichotillomania. Trichotillomania is an obsessive compulsive disorder where patient repetitively, recurrently pulls out their own hair. And when they pull out their own hair, you will see this patch like this. This is a patch which is irregular, which is bizarre shaped. It has broken hair of different lengths. And when you look closely, you can see these perifollicular hemorrhages as well. So this is trichotillomania. Treatment of choice, cognitive behavior therapy, which is the treatment of choice for obsessive compulsive disorders. If you have to go to drugs, then the drug of choice are the SSRIs. Drug of choice are the SSRIs. Is this clear? Now, these patients, if they eat their hair, that is trichophagia, and this can cause the formation of trichobezoar, which is a stone-like concretion made up of hair, which are undigested, and this happens in the stomach. So this is your trichobezoar. So the correct answer to this is option C. Now we come to question number 7. A 20-year-old child, this is not a child, a 20-year-old patient presents with patchy alopecia, nail findings as shown. What is the diagnosis? So the question tells you that the patient has patchy alopecia. Let us see what the image is showing us. Image has this particular finding in the center of the nail, as you see here. These are pinpoint depressions. So what we see here is pitting. Now, when you look at pitting, what you have to do? You have to look at the pattern of the pitting. So when you look at the pattern of the pitting, what do you see? This is regularly arranged. This is regular arranged, and these are fine pits. So when you see at a regular fine pitting, what do you have to suspect? You have to suspect alopecia areata. And the question itself is taking us towards one of the alopecias because it is telling us that there is patchy alopecia. See, there is one way of doing it that you know it's a patchy alopecia. You look at the regular pitting, you come to a diagnosis of alopecia areata. But other than that, in the alopecias, where would you get nail finding? Would you get a nail finding in androgenetic alopecia? No. In the telogen and the anagen effluviums? No. Now, when you come to the patchy alopecias, what are the patchy alopecias? Alopecia areata, trichotillomania, and Tinea capitis. In this, in alopecia areata, along with the patchy, yes, you will see the regular pitting. TTM, no nail finding. Tinea capitis, if at all, a patient can have onychomycosis, but onychomycosis would show discoloration, that would not show pitting. So when you look at the alopecias, alopecia areata will show this kind of a pitting, nothing with moth-eaten alopecia. Psoriasis will not show alopecia, and in psoriasis, there will be pitting, but the pitting is going to be coarse and irregular. It is going to be coarse and irregular. So when you see it on the nail, this will be arranged in a irregular manner. If this question would not have given us alopecia, it would have just given us nail. Then there would have been confusion whether it is areata or it is psoriasis. But by virtue of mentioning patchy alopecia, it anyway rules out psoriasis. So when you look at the pitting in psoriasis, it is this irregular pitting. And when you compare it with the pitting of alopecia areata, then in the alopecia areata, this is the Irregular pitting. This on its own is a NEET PG 2021 question where they gave an image of nail and they asked you what is the diagnosis. So here by giving us alopecia, they make our job easier. But if that was not given, then you look at the type of fitting. If it is an irregular pitting, it is psoriasis. If it is a regular pitting, this is areata. Tinea capitis, anyway, this is not the nail finding, and anyway, tinea capitis does not happen in a 20-year-old. I've told you, you have to consider tinea capitis only when the patient is a child. You will not consider tinea capitis in a 20-year-old. So, by virtue of that, also, tinea capitis is ruled out. So, this is in short about alopecia areata, which is an autoimmune disease. It is going to target the black hair bulb and those hair which are in anagen phase. So it is going to kill the black anagen hair, spare the gray hair, causes a chickney chameli type of patch where there is a well-defined patch with complete alopecia within the lesion, smooth hair. You see these exclamation mark hair and you see the kind of irregular pitting which is seen on the nail. So these are the three important images which you should be knowing along with alopecia areata. What is treatment of choice? Treatment of choice is intralesional steroid injection. Treatment of choice is intralesional steroid injection. Can you tell me what is the steroid which is used? Can you tell me what is the steroid that is used in the injections of alopecia areata? The steroid that is used is triamcinolone acetonide. The steroid that is used is triamcinolone acetonide because this is a long acting depot preparation. Depot means you inject it, it will slowly release over the next 3 weeks, and then we give the next injection after 3 weeks to the patient. So this is what is the meaning of depot preparations, which will have a slow release of the drug over time after you inject it. So the steroid that we use here is triamcinolone. Now coming to question number 8, a 20-year-old obese girl with irregular menstrual cycle presented with lesions as shown. All of the following can be used in the treatment except. So this is a patient who is obese. She has irregular menstrual cycle. And on the face, what do we see? We see a lot of acne, especially in the beard area near the jawline, and we see these dark coarse terminal hair again in the beard area. That is hirsutism. So the image gives us acne and hirsutism, text give us obesity and irregular menses. So this could be a patient who is suffering from hyperandrogenism. We cannot say what cause of hyperandrogenism, but we can say hyperandrogenism, irregular menses, obesity, could query be PCOS. So this is a patient who comes to us with features of hyperandrogenism. What are the drugs that we can give? Can we give spironolactone? Yes, this is an androgen blocker, very effective in treating these patients. Can we give clascoterone? What is this drug? What is this drug? Clascoterone. What is clascoterone? Clascoterone is a new drug which acts as a topical anti-androgen. So most of the anti-androgens that you read are oral drugs, but this is a topical anti-androgen and it's a new drug. So it is for the purpose of telling you this new drug that I've put it in the option here. So remember, clascoterone is topical anti-androgen. Danazol is a anabolic steroid. It has virilizing side effects. So it is going to create a state of hyperandrogenism in the patient and increase these problems, not decrease them. So you absolutely cannot give danazol. And what have they asked? Except. So you absolutely cannot give danazol in these patients. Cyproterone, obviously very effective, especially when you combine it with OCPs. It is very effective for patients who have irregular cycles with these kind of skin manifestations. For these patients, cyproterone works quite well. So what is the correct answer here? Danazol, you cannot give danazol. So this is what is hormonal acne. This is a question that was asked in NEET PG 2023, where the patient was obese, has hirsutism, has acne, and despite hirsutism on the face, these patients can have female pattern hair loss on the scalp. So remember, on some parts of the body, the hair increases, but on the scalp, the hair is going to reduce. There can be hoarseness of voice, there can be clitoromegaly, depending upon the extent of hyperandrogenism that they have. Infertility, irregular menses can be there as well. What is the scoring system for hirsutism? Just taking a point here. What is the scoring system for hirsutism? Do you know? How do we assess the severity of hirsutism? There is a score which is called as Ferroman Galway scoring. So this is the Rotterdam is different. That is for PCOS. This is a scoring that I'm asking only for hirsutism. Hirsutism is the Ferroman Galway scoring. So this is a different score that is used. Anyway, in this patient also you see hirsutism here, you see acne here, points towards hyperandrogenism. First of all, in the treatment, you will first evaluate the patient for hyperandrogenism. That is going to be your first step. You will find out why she has the problem, and then you will accordingly treat. The drugs are cyproterone, spironolactone, flutamide, clascoterone. These can be used. Is that clear to everyone? This is what is hormonal acne. Then I've just put a slide on the treatment of acne, not just hormonal acne. You should know for the rest of the acne, because every year in the NEET PG exam, they ask you one question on acne. INI, not as much, but they still ask. So for topical, for comedonal acne, which is grade 1 acne, the drug of choice are topical retinoids. Remember, you don't give steroids in acne. This is a question that was asked in the INI August 2020. We do not at all give topical steroids in acne. That is a adverse effect of steroids, which was a question in INI May 25. Adverse effects of steroids. So see, that's how they keep asking you. In one exam, they will ask you where is the disease where it cannot be given. In another exam, they will ask you the side effects. So they have these favorite topics which you should be knowing. Then for papular acne, add topical antibiotics. For pustular acne, add oral antibiotics. For nodulocystic acne, it is the oral retinoids, which are the drug of choice, given at a dose of 1 mg per kg per day. But remember, there is a very important side effect of teratogenicity. So the UPT has to be negative. There has to be a gap of 1 month between stopping the drug and planning a pregnancy. And what are the blood tests that you have to do to monitor? You have to monitor LFTs. You have to monitor the lipid profile, because oral retinoids can cause deranged LFTs and hypertriglyceridemia. So another way this question can be asked about oral retinoids is that you are starting a patient on treatment for nodulocystic acne. What are the blood tests that you will do for monitoring? So you should be knowing LFTs and lipid profile as the answer to that. Is that clear? Acne is very important. We cannot give topical steroids in a patient with acne. And this is a new topical retinoid. Please remember trifarotene. This is FDA approved. So this can be asked in the questions, that this is a newer retinoid. Clear to everyone? Is that good? Good to go? Very good. Now question number 9. A 28-year-old obese female presents with recurrent painful nodules, discharging sinuses in the axilla and groin. What is the most likely primary pathology? So this is someone who is 28 years old. She is obese. She has recurrent painful nodules, sinuses in the axilla and the groin. Where does that take you? In the axilla and the groin, I told you, in the axilla, there are only two things that you get. Either you get itchy, skin colored papules, which is your Fox Fordyce disease, or you get painful red nodules with sinuses and scarring. That is Hidradenitis suppurativa. Both of these disorders involves the apocrine glands. Both of these disorders involve the apocrine gland. What exactly is happening in Foxford-IC disease? Your apocrine glands are getting blocked. So there is apocrine miliaria happening in Foxford-IC disease. And what is happening in hidradenitis suppurativa? Hidradenitis suppurativa, the first thing that happens is hair follicle occlusion, and then your apocrine glands also become blocked. That is the second thing that happens here. So coming to the questions, is this an acrine gland infection? No. The diagnosis here is hidradenitis suppurativa. This does not involve the acrine glands. Is this apocrine gland infection? No, this is not really an infection. This is an inflammatory disease. This is not an infectious disease. This is not pyodermas. If this was pyoderma, it would not be recurrent. It would not really have sinuses in a normal young girl. It was not an immunocompromised patient that we are dealing with. So this is not infection as well. Is the sebaceous gland hypertrophy? That will also not present like this. So the primary disease that happens here is hair follicle occlusion, which is seen in hidradenitis suppurativa. So the only point of giving this question is that with HS you tend to read only about the apocrine gland. But remember, it is not just apocrine gland. This involves both hair follicle and the apocrine glands. And in fact, hidradenitis suppurativa is a part of what you call as the follicular occlusion tetrad. This is a part of follicular occlusion tetrad. What is a follicular occlusion tetrad? First disease that we have here is your pilonidal sinus. Then we have acne conglobata. Then we have dissecting cellulitis of the scalp. And fourth we have is hidradenitis suppurativa. So in surgery, you might have read this as the follicular occlusion triad. But when you add HS to it, it becomes the follicular occlusion tetrad. HS is also called as inverse acne. There is occlusion of hair follicle. You get these painful, deep-seated red nodules, abscesses, scarring in the axillae, nipple, and the groin. So it is the presence of these lesions in axillae, the recurrent lesions, that takes you towards hidradenitis suppurativa. Okay, that takes you towards hidradenitis suppurativa. Now, coming to question number 10. A patient presents with erythematous plaques covering more than 50% of the body surface area. On examination, the following finding was observed, which is not used in the treatment. So, erythematous plaques could be anything. That could be any and every disease. How do we know what they are talking about? For that, we have been giving this image where a bedside test is shown. So in this image, what do you see? In this image, you see this silvery white scale. So in this image, you see this silvery white scale. Now, red plaques with silvery white scale. Where does that take you? That tells you that it might be psoriasis. Yes, so we have psoriasis in our mind. Now, what do we see in between this scale? What do we see inside it? We see some area which is scratched, where you don't see scale, and you see the pinpoint bleeding within the scratch mark. So what is this sign? Where is this taking you? This is taking us towards what is called as the Auspitz sign. So what you see in the image here is silvery white scale. In the center, there is Auspitz sign positive. These are erythematous plaques. So this is probably psoriasis that this question is talking about. And this patient has more than 50% body surface area. So I told you, when it is less than 10% body surface area, we give topicals. When it is more than 10% body surface area, we give systemic drugs. So that is for sure that we have to give systemic drugs. Can we give phototherapy? Yes, we can give phototherapy. Can we give methotrexate? Yes, we can give methotrexate. These two we already know. Now, I have no idea about prednisolone and hydroxyurea. Ma'am didn't teach me what is hydroxyurea. But we know that hydroxyurea is also an immunosuppressive drug. Can it be used in psoriasis? Maybe, maybe not. I don't have any idea. But can we use steroids here? No, I have told you repeatedly throughout different classes that steroids are absolutely not used in a patient with psoriasis. The only indication for steroids is impetigo herpetiformis. If you use it in a normal case of psoriasis, stopping it can give a risk of pustular psoriasis or the Wurm-Busch disease. So steroids are not used. And hydroxyurea, not as much these days, but in the older times this was used. So the question is asking us what is not used. What is not used is prednisolone in a patient with psoriasis. So the question tells us red plaques. So these are the red plaques with silvery white scaling. We do the grit arch test where we see the Auspit sign positive. Then there can sometimes be a peripheral pallor when you treat psoriatic lesions. This is called as a ring of Warnoff, and there can be linear lesions along lines of trauma. That is called as Kovner's phenomena. So these are the three named findings that you should know with psoriasis: grit arch test, Auspit sign, ring of Warnoff, and the Kovner's phenomena. Treatment: methotrexate is generally the drug of choice, whether it is chronic plaque psoriasis, erythrodermic psoriasis, or a case of psoriasis with psoriatic arthritis. So this is generally the drug of choice. Acitretin preferred in a patient with pustular psoriasis. Cyclosporin, when rapid relief like a wedding or a meeting is coming up and you have to give rapid relief to the patient, in those cases, cyclosporin. Steroids only for impetigo herpetiformis, otherwise they are not used. These biologics also we have discussed. We can do anti-TNF alpha agents, anti-interleukin 17, 12, 23 inhibitors, interleukin 23 inhibitors. Indication for biologics is failure to first line drugs. So the drugs on the previous page, when the patient is not responding to them, then you treat them with biologics. And these are two new small molecules. Oral drug is apremilast, which is a phosphodiesterase 4 inhibitor, and JAK-STAT inhibitors. These are also used in psoriasis. So these are different drugs that are used, but remember, we don't use steroids. That is something that you should very well remember. Now, question number 11. A simple one here. A 45-year-old female presents with burning sensation in the mouth, especially while consuming spicy food. Oral examination reveals lesions as shown. What is the most likely diagnosis? So, this is the lady who comes with burning sensation in the mouth. Look at these lesions. What do you see on the undersurface of this tongue here? You see these lacy reticulate stria. Again, you see these lacy reticulate stria. So what you see in the image are these lacy reticulate stria. And there might be some redness here, which could be erosions. So this is lacy reticulate stria with erosions. What does this mean? That this is erosive oral lichen planus. This is erosive oral lichen planus. Erosive oral lichen planus is a disease where patient will have burning sensation when they eat hot spicy food. An image similar to this was given in the NEET PG 25. And what is the diagnosis here? Diagnosis here is oral lichen planus. Candidiasis would give us creamy white patches. It would not give us reticulate stria. Leukoplakia would be just a uniform white lesion. Aphthous ulcer will be a painful ulcer with a yellow slough on the surface and surrounding redness or erythema. Yes, there will be burning sensation in aphthous ulcers. Yes, there will be burning sensation in candidiasis also, but the physical examination would yield different result. The lacy reticulate stria here take you towards a diagnosis of oral lichen planus. So when you look at OLP, these lacy reticulate stria, which are the Wickham stria that take you towards LP, very, very favorite of the INI, is asking you the infection that is associated with lichen planus. The infection is hepatitis C. So this is a question that has been asked in the INI. Dental amalgam was asked when it was the AIMS exam. They have asked association of lichen planus with dental amalgam. which is the mercury fillings that we give in the tooth with cavities. And in the NEET PG25, they have recently asked lichen planus, the drugs that can exacerbate it. So the most important drugs are antihypertensives like beta blockers as and ACE inhibitors. They can trigger LP. Antimalarials like chloroquine can trigger, and ATT drugs like isoniazid can also trigger this lichen planus. So is this clear to everyone? These are the drugs that can exacerbate or they can trigger lichen planus. You should be able to identify when you see this reticular stria on the surface. This is the reticular OLP, but this is generally asymptomatic. Your patient does not come to you with symptoms. Symptoms happen more when it is erosive OLP, where within the lesion you see these red erosions. Here, patient will give us burning sensation on eating hot spicy food. And also remember, this is a pre-malignant lesion. There is a small, less than 1%, but there is a risk of squamous cell carcinoma that can develop in these patients. There is a risk of SCC that can develop in patients with mucosal LP. So on the skin, lichen planus will give you these purple pruritic papules. On the nail, it will give you pterygium, which causes permanent nail loss. On the scalp, it will give you lichen planopilaris, which again causes permanent hair loss. So remember, LP as a question can also ask the different LP features on different parts of the body, not necessarily one site. So you should be knowing that all these can occur simultaneously in a patient. The stria on the mucosa, the purple papules on the body, pterygium on the nail, and scarring alopecia on the scalp. So these are all features of lichen planus. Now coming to question number 12. A 19-year-old male presents with multiple erythematous scaly lesions on the trunk and the proximal limb. There is no palmoplantar involvement. There is no systemic symptoms. What is the typical scaling in this condition? So, yes, antimalarials as a drug are involved in so many skin eruptions. The most important eruptions along with antimalarials are it can cause psoriasis, it can cause lichen planus, and they have also been asked as a trigger for erythema multiforme, which is a NEET PG 2019 question that antimalarials can trigger erythema multiforme. So as a drug, these are good drugs for a lot of diseases in derma, but they can have their own side effects as well. So remember, the three important eruptions with antimalarial groups are psoriasis, lichen planus, and erythema multiforme. Okay, so this is about skin LP. Now coming to question number 12, tell me what is the diagnosis? In the question, you can't really make out much from the text. Erythematous scaly lesions, no palm sole, no systemic involvement. No, you can't make out much from here. So let us look at the image. What is the image showing us? Image is showing us red scaly plaques, yes, but a lot of them seem to be, this is also wishful thinking. I am just thinking that this is how they seem to be looking, but this is what I can make out on the image. So what do you see on the image here? You see something that is called as the Christmas tree pattern. And when you have these kind of erythematous scaly lesions on the back in the Christmas tree pattern, you have to think of P. rosea. So the diagnosis here is P. rosea. But why is the question telling us there is no involvement of palms and soles and no systemic symptoms? Why is the question telling us this? Can anyone tell me why? Because I will tell you, clinically, whenever I see a patient of P. rosea in my OPD, and it's a young adult who normally comes with P. rosea, the very important DD of P. rosea is secondary syphilis. We have to rule out secondary syphilis. In secondary syphilis, on the palms and soles, you will see the coppery brown lesions, and patient may have systemic symptoms as well. So this sentence here no systemic symptoms, no involvement of palms and soles, is actually for you to rule out secondary syphilis if this is there in the option and this was a question asking you the diagnosis. Okay, so the purpose of giving this sentence is to rule out secondary syphilis. However, the question is not really asking us the diagnosis here. So what we have to do is just tell what is the typical scaling here. So what is the typical scaling? Give me the answer. What is the typical scaling that we see here? Typical scaling here is the collarette scaling. That's the classic scaling in P. rosea. Furfuraceous scaling is seen in Pityriasis versicolor. Micaceous scaling is seen in psoriasis, and another disease that is Pityriasis lichenoides cutica, don't need to bother. Sandpaper scaling is seen in scarlet fever. And this can also be seen in certain viral exanthems. But these are the classic scales here. So just in short about P. rosea, because this is again a very favorite of the INI, the first lesion that appears is your herald patch, which is a single asymptomatic lesion on the trunk. After that, multiple lesions will appear along the lines of cleavage in a Christmas tree pattern. And when you look at the individual lesion will show this erythematous annular plaque. Remember, I told you that there are red annular plaques in P. rosea. Those red annular plaques have this collarette scaling. So that is the most important point that you have to remember here. And in the triggers, HHV7 or 6 reactivation can cause P. rosea. You have to differentiate this from P. versicolor also. P. versicolor will show hypopigmented scaly macules with furfuraceous scaling. They will not be red. They will be generally hypo or hyperpigmented. And coming to some other important scales in dermatology, this was asked in the INI 22 as a match the following. So a silvery white scale with auspit sign is seen in psoriasis. This was also asked in the INI November 25. Furfuraceous scale, Pityriasis versicolor, which gives you a scratch sign positive. Collarette scale in P. rosea. Greasy scale in seborrheic dermatitis. Capitax sign in DLE, which again was asked in the INI 25. A trailing scale is seen in erythema annulare centrifugum. Sandpaper scale in actinic keratosis and scarlet fever. But if you want to remember, yes, one smaller lesion with sandpaper scaling, then this is actinic keratosis. Micaceous scale, Pityriasis lichenoides chronica, and also psoriasis. So both of these can show micaceous scale. Brani in Ichthyosis vulgaris, dark black scales in XLRI, armor-like scaling in harlequin ichthyosis, and double-edged scale in ILC, which is seen in Netherton syndrome. In Netherton syndrome, in August 2020, they gave an image of bamboo hair. So this bamboo hair is Trichorexis invaginata, which is also seen in Netherton syndrome. So see, in this name slide, there are so many important diseases with their scales, which are questions in the INI, which can be asked as multiple choice questions as well. So you should be able to answer these important scales in dermatology. Now coming to question number 13. A 36-year-old patient presents with flaccid bullae, crusted erosions, predominantly over the face, scalp, upper chest, upper back. Histopath is shown below. What is the likely diagnosis? So whenever a question says flaccid bullae, you have to go towards pemphigus. So you have to go towards pemphigus. Rest, everything is out the minute it says flaccid bullae. So bullous pemphigoid is out. IgA pemphigus does not really ever come in the question, so that is also out. Now you have to choose between foliaceous and vulgaris. With just flaccid bullae, I cannot make out any difference. Now let us see what is the histopath showing us. In the histopath, this is your basement membrane. And this is the stratum corneum. This is your stratum basale. Split is in the epidermis. So this is, of course, histopath of a pemphigus type of a lesion. Now, The split is just below the stratum corneum. So this is a subcorneal split. So when you have a subcorneal split with floating acantholytic cells, where do you go? Whether you go towards vulgaris or you go towards foliaceous, where do you see a subcorneal split? A subcorneal split is seen in pemphigus foliaceous. So this is a classic question where they are just giving you the skin involvement. Had they told us mucosa, it would have been easier for us. But they didn't tell us the mucosa. They want us to differentiate based upon the histopath. So in the histopath, a subcorneal split goes in favor of pemphigus foliaceous. See, this is a very important slide that helps you differentiate. Both of these on the skin will come with flaccid bullae. Both of these will have erosions, but they will be more painful in vulgaris. They will be more crusted in foliaceous. But mucosa is the clinical feature that helps us differentiate, because you get mucosal involvement in the form of oral ulcers in the question in vulgaris, but you don't get any mucosal involvement in foliaceous. Histopath gives us a suprabasal split with a row of tombstone appearance. So see, this is an image. This is the basement membrane. This is your stratum basale. The split is just above the stratum basale. So this is a suprabasal split. And you see these basal cells, they are attached to the basement membrane, but they are not attached to each other. This is your row of tombstone appearance. Very, very, very important questions for INI and NEET PG. This suprabasal split with row of tombstone appearance. In pemphigus foliaceous, another image. This is the basement membrane. This is your stratum corneum. Again, the split is below the stratum corneum. So this is a subcorneal split. So either you differentiate them based upon the mucosa, or you differentiate them based upon the histopath, because the skin involvement is common. The DIF is common, which is the fishnet IgG. This was an image in the NEET PG 24 also. So these two are common. You cannot differentiate based upon them. You have to look at either the mucosa or the histopath. Am I clear with everyone? This is how you differentiate vulgaris from foliaceous. So coming to this image, look at the histopath. This is a case of pemphigus foliaceous. Now, coming to question number 14. A 70-year-old man, so this is an elderly patient who presents with intensely itchy, tense blisters on the lower abdomen and the inner thigh. Which of the following cells are typically seen in the Zang smear of this condition? So this is an elderly patient. This is an elderly patient with tense, itchy bullae. When you say tense, itchy bullae, where do I go? I go towards pemphigoid, which is your bullous pemphigoid. This is where I go. Other points in favor: old patient, lesions on the lower body. So this is a classic case of bullous pemphigoid. What will be seen in the Zank smear? Will I see acantholytic cells? No. Acantholytic cells are seen in pemphigus. Will I see mast cells? No. Will I see eosinophils? Yes. Neutrophils are seen in dermatitis herpetiformis. Eosinophils are seen in bullous pemphigoid. So what is the correct answer here? Correct answer here is option B, that is bullous pemphigoid. This is another INI question, in a different form. This was asked in INI in December 2020. Bullous pemphigoid shows a subepidermal split with eosinophils. That is what the question was. So please remember, old patient with tense bullae, think of bullous pemphigoid. Here, the Zang smear will show eosinophils. The subepidermal split will also have eosinophilic infiltrate in the dermis, and the DIF is going to show a linear IgG and C3. This question has been asked in the INI many a times. So bullous pemphigoid is a very, very, very favorite of the INI CET. Remember, this can show linear IgG and C3 deposition at the dermoepidermal junction. Now coming to question number 15, a 40-year-old male presents with intensely pruritic vesicles, excoriations on the elbow, knee, and the buttock. He reports occasional bloating and diarrhea. Which systemic condition is associated with this dermatosis? The image is also showing us a few vesicles and excoriations. I see scratch marks here. So it shows us vesicles and excoriations in the elbow. Question is also showing us vesicles and excoriations in the text. There is a GI complaint. What do you think is the diagnosis? And what is the correct answer? Very good. Very good. I want more of you to give an attempt to this question. More of you to attempt it. Yes. So the correct answer here is the skin diagnosis is dermatitis herpetiformis. So the skin diagnosis here is dermatitis herpetiformis by virtue of the classic clinical feature and the site of the rash, bloating and diarrhea. Take it towards celiac disease, which is associated with DH. Hepatitis C, no. HIV, no. SLE, no. So the correct answer to this question is celiac disease, because that is a disease which shares association with DH because of the common antigen. Transglutaminase, even though the type of enzyme TG1, TG3, these are different in both these diseases, but it is transglutaminase after all. In DH, it is TG3, and in celiac, I think this is TG1. Just confirm it. So even though the subtype of the enzyme is different in both these diseases, but they are associated with each other. Dermatitis herpetiformis is associated with DH. You see these classic pruritic excoriations and vesicles on the extensor surfaces. They are always bilaterally symmetrical, and there is no mucosal involvement in DH. Histopath shows classic papillary tip neutrophilic abscesses. So these are the papillary tip neutrophilic abscesses. DIF shows a granular IgA at the basement membrane zone. So these are all, like, I'm repeating these points because for the purpose of exams, these are very important. A question on dermatitis herpetiformis association with celiac was asked in NEET PG24, similar question, NEET PG25, similar question, FMG July 24. So very, very important. This is treated with a gluten-free diet with dapsone. So remember, a gluten-free diet is also given in patients with dermatitis herpetiformis. Now, question number 16. A patient presents with pigmented lesion shown in the image. What is the diagnosis? So what is the diagnosis? What is the pigmented lesion that you see in the image? Yes, yes, come on, I want you all to answer. Please attempt. There is no negative marking here. All of you have to attempt along with me. So what do you see in the image? In the image, this is a girl who has this unilateral lesion on one side of the face. So the lesion is unilateral. That is the first thing that you have to note. It is on one side of the face. Secondly, look at the color. The color of the lesions is blue-gray in color. So this is not the brown-black pigmentation that you normally see. This is blue-gray in color. And when you look at the eyes, even the sclera is blue-gray pigmented. So sclera is also pigmented. When you have a unilateral blue-gray lesion like this, what is your diagnosis? Is this Becker's nevus? No, Becker's nevus is brown. It has hair on it. So this is not Becker's nevus. Cafe au lait macule is again brown. Nevus of Ito is blue-gray, but this is on the back. The correct answer here is nevus of Ota, because nevus of Ota is on the face around the eyes like this. So this is going to be unilateral. It is going to have blue sclera, blue gray lesions on the skin. So this is nevus of Ota. How do you remember? O is Ota, O is ophthalmic. This is around the eyes, involving the V1 and V2 division of the trigeminal nerve. So this is nevus of Ota. Nevus of Ito, again unilateral blue-gray lesion, but in the acromioclavicular area. Ito is I is for inside. So remember, nevus of ito is always inside on the covered areas where you wear your shirt. So this is in the acromioclavicular area. Becker's nevus is a nevus which comes at puberty. The background is brown. It has dark black hair on it. It is not blue-gray in color. So Becker's nevus is very different. This is brown. Cafe au lait macule is just a brown spot. I'll show you that with neurofibromatosis. Not here. So the correct answer to that was nevus of Ota. Now coming to question number 17. A 19 years old patient presented with depigmented lesion with leukotrichia on the right side of the face. Lesions appeared at 6 years of age. Then they stabilized over the next 4 to 6 months. What is the appropriate treatment? Come on, attempt. Come on, attempt. I want you to attempt this question. So, a lot of you have already made the correct diagnosis. Unilateral, it is on right side of the face. This is unilateral. This is depigmented white. It has leukotrichia. It appeared in childhood and then it stabilized. Together, this goes towards a diagnosis of segmental vitiligo. This goes towards a diagnosis of segmental vitiligo. So when it goes towards segmental vitiligo, now the patient is 19 years of age and she had the lesion at 6 years. So anyway, 13 years have already passed. What would you do in treatment? Would you give topical steroids? Topical steroids don't work even in the active phase, so they are not going to work later in segmental vitiligo. This does not really have an autoimmune pathogenesis. There is more of a neurogenic component to the pathogenesis of segmental vitiligo. So the conventional immunosuppressives, which otherwise work in vitiligo, they don't work in segmental vitiligo. So topical steroids are not going to work. Narrowband UVB does not work. Methotrexate again will not work. I told you immunosuppressants don't work. The only way we bring back color is by transporting melanocytes from the normal skin to the vitiligo area. That is called as surgical grafting. So what we do in surgical grafting is that there are different types of surgery. There is split skin graft, there are punch grafting, there is non cultured melanocyte transfer. So the whole purpose is that from the normal skin, you take the brown color, which is the melanocytes, and you graft it to the vitiligo area. There they will grow, they will bring back color. So that's the whole purpose of surgical grafting, which we do in vitiligo, that we take melanocytes from the normal skin and we bring it to the vitiligo area. So the correct answer to this is surgical grafting. This is segmental vitiligo. You already know this will be unilateral. This will be in a dermatomal distribution. This will come early in childhood and then this will stabilize. Stabilize is a question in INI 24. This is the most stable type of vitiligo. See, inherently vitiligo is unstable. Lesions will keep coming and going, increasing in size, repigmenting. So this kind of a low grade activity is always there in vitiligo lesions. They never remain the same for a lot of months. So vitiligo is an inherently unstable disease, but in segmental vitiligo it will remain stable. Once it comes, it achieves its size, then there will be no change in the lesion throughout the life of the patient. That is what is called as a stable disease, and amongst all types of vitiligo, this is the most stable form, and it almost always has leukotrichia, that is white hair within the lesion. Since its pathogenesis is not really autoimmune, it does not respond to steroids. It only responds to surgical grafting. Now, along with this, I will just take a few minutes to tell you, if this was a question asking you the diagnosis, then why would it not be piebaldism? Piebaldism will be just on the forehead with a white forelock of hair. Nevus depigmentosus will not be a depigmented lesion. This will be a hypopigmented lesion. and it will be present since birth. So this is non-depigmentosis. Hypomelanosis of feto will be white lines in a Blaschkoid pattern, and these will also be present since birth. So if this question was asking you the diagnosis which has been done in the INI CTs, the segmental vitiligo, topical and oral steroids. See, steroids are mainstay of treatment, but they are mainstay of treatment for vitiligo. Yes, overall we write vitiligo for that, but actually it is the non-segmental vitiligo, which is vitiligo vulgaris, focal vitiligo, mucosal vitiligo, vitiligo universalis. So it is for non-segmental vitiligo that we use steroids. Topical steroids don't really work in segmental vitiligo. Okay, if it does not specify, then yes, but if it is actually asking you about segmental vitiligo, then you should know that it will not respond to steroids. That is the tricky part of these questions. Now, you know you have read steroids and vitiligo, but the distinction of segmental versus non-segmental, that is the additional step. That is something that you have to read for the exams. Is that clear now? Is that clear? Is that distinction clear? See, exams are going one step forward. So we have to go one step forward. We have to know the certain tricky situations that they can ask you in the exam. Now, question number 18. Match the following. Again, very favorite of the INI type of exams. They love asking you contact allergic dermatitis. They love asking you the triggers for contact allergic dermatitis, and match the following is like a party for them. They can ask 4 different things in one go. Phytophotodermatitis. Phyto means plant. So which is the plant that causes dermatitis? Parthenium. So this goes to Parthenium. Where is one with C? One with C is only one option. Okay. Bindi dermatitis, PTBP. This is 2A. Hair dye dermatitis, paraphenyl diamide. 3D. Cement dermatitis, potassium dichromate. So what is the correct answer? The correct answer is option B. You know, in these kind of questions, if you know even one, then that kind of makes it easy to see the others. So this is option B, the correct answer here. This is option B, the correct answer here. See, contact allergic dermatitis, most common metal to cause it is nickel. So for there, you will have it on the places where you wear the artificial jewelry, wrist strap, belt buckle. These are all the areas where you can see nickel dermatitis. Cement dermatitis will be in a labra on the hand. The chemical is potassium dichromate. For hair dye dermatitis, a question asked in NEET PG 2023, patient has facial swelling, vesicles, oozing on the scalp and the face. The chemical is paraphenylene diamine. And for bindi, there will be a red itchy rash where they apply the bindi. The chemical is PTBP. How do you remember it? You remember it with the name. C for cement, C for chromate, D for dye, D for diamine PPD, B for bindi, B for PTBP. So this is how you can remember these chemicals which cause this rash. And airborne contact dermatitis, which is the phytophotodermatitis, here the plant responsible is Parthenium hysterophorus. This will be a farmer with a itchy rash in the exposed parts of the body. Another question that the INI loves asking is, how do you diagnose, how do you confirm the diagnosis of contact allergic dermatitis? That is done using a test that is called as patch test. Reading at 48 hours and 96 hours. So these are the different kind of questions that you can get in contact allergic dermatitis. What is the principle? DTH. What is DTH? This is the type 4 hypersensitivity. Contact allergic dermatitis is type 4 HS, and patch test is also based upon type 4 HS. Coming to question number 19. A child presents with itchy plaques over the bilateral, cubital, and popliteal fossa. What is your diagnosis? So nothing much is given in the text, nothing much is given in the image where it is just giving us a photo of a non-specific rash. So what do you think could be the answer here? What do you think could be answer here? Yes, very good. I want others to attempt. Very good. So, is this psoriasis? First of all, psoriasis is non-itchy. It is asymptomatic. Secondly, psoriasis is on the extensors. So this is not psoriasis. Okay, so this is not psoriasis. Pemphigus vegetans, yes, is on the flexures, but these are lesions which are vegetating. There is a lot of granulation tissue. They are not itchy, they are painful. So this is not pemphigus vegetans. Dermatitis herpetiformis, we just saw, will be vesicles which will be itchy, but again, these will be on the extensors. The only disease where it fits is atopic dermatitis. So this is also a INI PYQ of the last 5 years. Nothing much given in the text. You have to eliminate the other options to come to the correct answer. So this is atopic dermatitis. Atopic dermatitis happens due to deficiency of filaggrin. This is a chronic relapsing remitting disease. Itching is an essential criterion. Another hint which you can get in the exam is the presence of an associated atopic disease like allergic rhinitis, asthma, food allergies. When this is present either in the patient or in the mother, like mother having history of asthma, this was there in the recent FMG January 26 paper. Child with rash and the mother having asthma. Then in the NEET PG 2019, again, child with a rash, mother having asthma. These are all points which are subtle hints in the exam that take you towards the diagnosis. When they give you an image of infantile atopic dermatitis, this will be generally on the face. Childhood AD will be in the fossa, which is your most common site being the cubital fossa, and adult AD will also be in the flexures. So the classic sites help you in diagnosis. Since in this question, this is a child, so this is childhood atopic dermatitis, you see that the rash is in the flexures. So the typical site also helps you in achieving the diagnosis. Another image that can be asked in the exam is these extra intraorbital folds, which are called as Denny Morgan folds, loss of outer one-third of the eyebrow, which is called as Hertog sign. These are other features of atopic dermatitis. Doing it in a little detail, because as a question, this is an important disease amongst the eczemas. Either they're asking you contact dermatitis or they're asking you atopic dermatitis. Topically treat with steroids. Tacrolimus, crisaborole is a topical phosphodiesterase 4 inhibitor. So oral was apremilast, used in psoriasis and psoriatic arthritis. Topical is crisaborole. JAK inhibitors like ruxolitinib and pardacitinib are used. Biologic, the used one is dupilumab, which is an interleukin 4/13 inhibitor. So this is the treatment for atopic dermatitis. Remember these drugs. These are questions that can be asked in the exam. Now, question number 20. An 8-year-old boy presents with lesions as shown in the image. What is the diagnosis? So again, this is a question where the text is not giving us much. It is the image that we have to see. What do we see in the image? We see multiple hypopigmented macules. I can't really make out any scaling here. All that I can see in the image is multiple hypopigmented macules on the face. That's what I can see in the image. Now, which disease is this? Is this vitiligo? No, vitiligo will be white. We just saw it will be depigmented. It will not be hypopigmented. So this is not vitiligo. Post-inflammatory hypopigmentation, there has to be a history of some rash or any other injury which heals with a white spot. That kind of history is not given here. So this is not vitiligo, this is not post-inflammatory hypopigmentation. Now you have to choose between indeterminate leprosy and P. alba. A very important feature is scaling. Scaling is not mentioned in the text, it's not visible in the image. I cannot differentiate based upon the scaling. So the only point that helps me in differentiating is that these lesions are multiple. Indeterminate Hansen's will generally have a single lesion. Pityriasis alba will have multiple lesions. So that is the only way that I can differentiate in this image. So remember, oh, no problem. See, these kind of tests are preparing you for what the exam can give us. Exam, but वैसे exam does not throw any googlies at us. In exam, the images are always classical. So it's okay if in certain images you could not make it out in the test. But I hope during the discussion, all that is clear. Break will be after this question. Don't worry. After the 20th question, we'll be taking the break. So when you look at indeterminate leprosy, it is the single lesion which takes you towards indeterminate leprosy. Plus, if this was indeterminate leprosy, they would have given us a history that this is a child who lives in endemic area. There is no scaling, no loss of sensation. All this takes you towards indeterminate leprosy. But for pityriasis alba, there will be multiple lesions and they will be scaly. Scaling has to be mentioned in the text. You can't really make out scaling in the image. So see in the question also, when I am writing the description, all that I can see is that there are hypopigmented macules. I cannot make out scaling. So if they write it in the text, yes, there is scaling. Don't worry about the image. Image may not always show you the fine scaling. Look at the other points to come to your diagnosis. So here the only point that I could use was that these lesions are multiple. Single lesion, endemic area, indeterminate leprosy. Multiple lesions, scaly. This is pityriasis alba. So this is an important differentiation that you should be able to do. We'll start with question number